Hello everyone. Am I clearly visible, audible to you guys? Kindly someone give me a thumbs up in the chat box if I'm clearly visible, audible. You have to give me a minute to confirm if I'm clearly visible, audible. I will start the lecture ahead. You have to give me a minute. Just a second. I hope it's working. Yes, is it? Yes, I hope it's working. Yes. So I welcome you all for today's session. A very, very good afternoon to all of you. So just a second. So there is some icon coming on my face now. You cannot see my video clearly, right? Can you see my video clearly? Can you see my video clearly? Just a second. Yes, I can see it now. Okay, anyways, I will continue. Just a second. So yeah, so I welcome you all for today's session. A very, very good afternoon to all of you. This is episode 3 of Renal System. I am Dr. Priyanka Sachdev here, and um, today morning I have started renal pathology. So in renal pathology, we have started the various type of glomerulonephritis, studying the various type of glomerulonephritis in a comparative manner. So today morning, we have already seen the pathogenesis of glomerulonephritis. We have seen the anatomy of the kidney, the anatomy of the nephron, the structure of the glomerulus, the structure of the filtration barrier. We have seen the various type of pathogenesis of glomerular injury. It can be antigen antibody mediated, it can be cell mediated, it can be complement pathway, alternate pathway. We have seen all of them. Now we have started the glomerulonephritis. In the glomerulonephritis, we know that there are 9 type of primary glomerulonephritis which we have started studying in the morning. So the first one is the Apgn, which we have completed in the last lecture, also known as PSGN. Those who have missed, please watch the recording after this. You can't afford missing that. The second is the RPGN, rapidly progressive glomerulonephritis, that also we have completed in the last lecture. So Apgn, also known as PSGN, we have completed in the last lecture. RPGN is also completed the last lecture. The third one is the MCD that we have completed in the last lecture. And now I am starting from membranous onwards. So in this lecture, I will start with membranous glomerulonephritis, proliferative glomerulonephritis, and the remaining one, focal segmental glomerulonephritis, glomerular sclerosis, IgA nephropathy, and chronic. So first, I will be finishing these primary glomerulonephritis, the remaining one, and after that, I will continue with the secondary glomerulonephritis and hereditary glomerulonephritis. So what you are asking, Deepak? Please complete general pathology first, please, ma'am. So I'm taking 2 courses, Deepak. One on the YouTube and one on the special classes. On special classes, I'm continuing with the general pathology, and on YouTube, I'm continuing with the systemic pathology. So if you want to study general pathology, stay connected on the special classes. So on special classes of Unacademy, more or less, I will complete the entire general pathology and hematology. YouTube is specifically for systemic pathology. You got your answer? I guess you. So let me continue with the primary glomerulonephritis first. Shall I continue? Give me a minute. You have to give me a minute. Right. Okay. And these are the secondary one. First, I will finish the primary glomerulonephritis, and in the secondary, I will teach you lupus nephritis, that is SLE, diabetic nephropathy, amyloidosis, good pasture we have already completed in type 1 RPGN if you know, and HS purpura. And in the hereditary one, I will be completing this. So first, I will help you. Again, we will compare the first 3 glomerulonephritis that we have learned till now in the first 5 minutes of the lecture, so that we have an overview that what we are going to do ahead. So we have completed APGN, RPGN, and MCD till now, and then we will continue with membranous. So just Sachin, I will require 5 minutes the revision, and then I will continue ahead. So give me a minute for that also. Let me move on the slide of the comparison directly, skipping the first 3 glomerulonephritis that we have already completed. Okay. I will be continuing with the third one again because MCQs of the third one are remaining. We have not completed the MCQs of the third one, I guess, right? So I will be continuing with the MCD. So we have completed APGN, we have completed RPGN, we have completed MCD also. So etiology, we have seen that APGN, also known as post-streptococcal glomerulonephritis, RPGN, also known as crypsenteric glomerulonephritis, and MCD, minimal change disease, also known as nil deposit disease or food process disease. First learn the other names given to these glomerulonephritis, right? After that, coming on the etiology or etiopathogenesis of each of them. APGN is due to antigen antibody immune complexes formation, that is in situ. It is in situ deposition of the antigen antibody complexes against a planted antigen. Who is the planted antigen here? The planted antigen is the bacteria. You know the name of the bacteria. It is group A beta streptococcus bacteria, that is known as gas bacteria. You know the complete etiology, I guess. In RPGN, we have seen type 1, type 2, type 3 RPGN. Type 1 RPGN is Goodpasture syndrome, that is anti-GBM disease. Here also in situ deposition is there, but against a fixed antigen, not the planted antigen. In type 2, again it is PSGN only, so it is the planted antigen. And in type 3 RPGN, it is the post-immune disease. So no antigen antibody complexes are there. It is cell-mediated immunity. We came on the gross of each of the following. So in APGN, the gross is flea-bitten kidney. You already know that flea-bitten kidney. In RPGN, the gross is large white kidney. And in minimal change disease, the gross is normal. We have already discussed the normal gross. In light microscopy, electron microscopy, and immunofluorescence microscopy, we have to say 3 microscopy. In light microscopy, in APGN, the size of the glomerulus is increased. In RPGN, also the size of the glomerulus is enlarged. Glomerulus is hypercellular in both of them, and most of the cells are inflammatory cells, neutrophil and lymphocyte. And glomerulus is proliferative in both of them, hyperproliferative. The only difference between RPGN and APGN is that in RPGN, crescent is the hallmark. You already know what is crescent, right? In minimal change disease, light microscopy is absolutely normal. That's why it is known as minimal change disease. Minimal means there is minimum change on the light microscopy. In electron microscopy, we have already seen that here the deposits are subepithelial deposits. Here in type 1, the deposits are intramembranous. In type 2, again subepithelial, and in type 3, no deposits are there. In minimum change disease, it is flattening. It is flattening which is seen. Flattening of the food processes, we already know the meaning. Immunofluorescence, the composition is same everywhere, IgG plus C3, so I'm not repeating that. So that is the summary till now. Let me start the next one, membranous and membranoproliferative glomerulonephritis. Shall I continue with that? Give me a thumbs up. So I am continuing with, just a second, membranous and membranoproliferative glomerulonephritis. So I will take the next two together. So first I will teach you membranous and then membranoproliferative, and we will see the polls together. Both of them, I will launch the polls together. So what is the difference between membranous and membranoproliferative? I'm going to teach you in sequence now. Membranous glomerulonephritis and membranoproliferative glomerulonephritis. What is the difference between the two? What is the difference between the two? As the name indicates, in the membranous, there is thickening. There is thickening of the basement membrane, glomerular basement membrane. That is membranous, the meaning of the membranous. In membranoproliferative, membranous component is there. So thickening of glomerular basement membrane is also there. But the difference is proliferative. So proliferation means hypercellularity. Here hypercellularity is also a feature. Here cellularity is normal. It is not hyperproliferative. Have you got the difference between membranous and membranoproliferative? The name itself says its meaning. In the membranous glomerulonephritis, only membrane is the thickening of the glomerular basement membrane is there. And in membranoproliferative, along with the thickening of the glomerular basement membrane, proliferation, that is hypercellularity, is also there. You got my point? If you got my point, give me a thumbs up. Vidika, have you got it? Sachin, have you got it? So let me start the membranous first. The membranous is also known as epimembranous nephropathy, and it is the most common cause of nephrotic syndrome in adults. Yes. So etiopathogenesis. So I will tell you the etiopathogenesis here. Let me draw the basement membrane. Let me draw the filtration barrier. In the filtration barrier, this is the basement membrane. You can see this is the basement membrane. On one side, we always have endothelium, right? And on other side, we always have visceral podocytes. These are the visceral podocytes, right? Now, visceral podocyte have a protein inside that. Like the basement membrane is made up of type 4 collagen. I have taught you in type 1 Rpgn. This is the type 1 collagen, type 4 collagen present in the glomerular basement membrane. So in the same way, the visceral podocytes have a protein in it. The name of the protein is glycoprotein 330, GP330, glycoprotein 330. It is like a protein, same as that of collagen. So it is a self protein. Normally body doesn't make antibodies against it, but sometime in some autoimmune diseases, the immunity of the body become deranged, the immunity of the body become mad, and body start forming antibodies against the GP330 protein. So what will happen? This antigen is fixed antigen there. It is not planted here. It is already present there. So it is fixed antigen there. It is fixed antigen. Now compare and contrast this with PSGN, post-streptococcal glomerulonephritis. In post-streptococcal glomerulonephritis, also we are having antigen on the podocyte, but that antigen was a bacteria. Here the antigen is the protein GP330. That antigen was planted here, and this antigen is fixed there. So here also antigen antibody complexes will be formed. So let me draw the antigen antibody complexes. Antibody will form. The antibodies are autoantibodies. So these autoantibodies will come and bind here and form antigen antibody complexes. So here also in situ antigen antibody complexes are formed against a fixed antigen, and it is an autoimmune disease. You got my point? What is the fixed antigen there? The fixed antigen is glycoprotein 330. It is a component of the podocyte. What is the location of the deposit? Siddhika, Sachin, Mushin. What is the location of these deposits? Is it intramembranous? Is it subepithelial? It is subendothelial? Yes, it is subepithelial. It is subepithelial in the same way as that of PSGN. Everyone give me a thumbs up. Everyone, have you got it? First give me a thumbs up. Have you got it? So this is the pathology. This is the pathogenesis. So draw a flow chart. What I have explained you, draw the flow chart. So immune complexes are formed. So the podocyte have a protein. The name of the protein is glycoprotein 330, right? Because it is 330 kilodalton in weight. That's why it is known as glycoprotein 330, right? It is located on the podocytes. The body form antibodies against this. It is a fixed antigen in the autoimmune diseases. That's why in situ antigen antibody complexes are formed, and these are absolutely right. These are subepithelial Mushin Sachin. Absolutely, it is subepithelial in location. So this is the flow chart. So antigen here is GP330, which is a component of podocyte. That's why it is a fixed antigen. So antibodies are formed against it. Antibodies are formed against it. And these antibodies will form antigen antibody complexes against the fixed antigen, and that will lead to acute renal failure. This is the diagram. Now same diagram I have shown you in PSGN also, post-streptococcal glomerulonephritis. You can see the podocytes. On the podocyte here, the red color antigen here is GP330, which is a fixed antigen. And if I talk about PSGN, the red color antigen here, this diagram is same. But the red color antigen is the bacteria, group A beta streptococcus bacteria. Now this is planted antigen, and this is fixed antigen. You got my point? So till now what I have taught you, the first glomerulonephritis I taught you is PSGN or APGN. One and the same thing, post-streptococcal glomerulonephritis or acute proliferative glomerulonephritis. Then I taught you RPGN, rapidly progressive glomerulonephritis type 1. Then I taught you type 2. Then I taught you type 3. After that, I taught you minimal change disease. And after that, now I am teaching you membranoproliferative glomerulonephritis. I want to compare etiopathogenesis till now. Of all the glomerulonephritis I taught you till now. Have you got it? Have you got it? Yes? Have you got it? So you tell me. So what is happening? You tell me. So in PSGN or APGN, a bacteria is coming. The name of the bacteria is gas bacteria, group A beta streptococcus bacteria, that is coming. That is causing tonsillitis or skin infection. So imagine a person is having tonsillitis or a skin infection of group A beta streptococcus. From the tonsil and skin, the bacteria is going in the blood, right? From the blood, the bacteria is going in the kidney. In the kidney, it gets deposited on the podocyte. It gets deposited. That's why this antigen is planted antigen. This antigen is planted antigen. Now body will form antibodies against it, and antigen antibody complexes will be formed in situ against a planted antigen. This is the complete story. In type 1, here the antigen was group A beta streptococcus antigen. Here the antigen is type 4 collagen, which is a component of basement membrane. That's why it is an autoimmune disease. So type 4 collagen of the basement membrane, uska alpha 3 chain NC1 domain is the exact antigen. Body will form antibodies against it, which are actually autoantibodies, right? So antigen antibody complexes formed here also, but this antigen is fixed antigen. It is not planted. It is initially present here only. So it is a fixed antigen. So antigen antibody complexes here formed again in situ, but against a fixed antigen, not the planted. See, here also in situ antigen antibody complex formation, here also in situ. But here the antigen is planted and here the antigen is fixed. That is the difference between the two. Type 2 is same as that of this. So another name given to PSGN is type 2. So same story is repeated here, right? So same story is repeated of Apgn is the type 2 RPGN only. In type 3, there are no deposit because it is cell mediated. Cell mediated means T lymphocytes, CD4, CD8 lymphocyte will cause the damage to the filtration barrier. If we talk about MCD, again it is cell mediated. So no antigen antibody complexes are there. Now coming on Apgn. In Apgn, what is the antigen? Antigen is glycoprotein 330, which is a component of podocyte. Again, it is a fixed antigen, not the planted one. It is a fixed antigen. It is already present there, and body is forming autoantibodies against it. So these autoantibodies are going to the antigen, and antigen antibody complexes are formed. So these antigen antibody complexes are formed in situ against a fixed antigen which is present on the podocyte. Everyone give me a thumbs up. Have you got the complete picture what I want to explain you? So in PSGN here, since the bacteria got deposited on podocyte, so antigen antibody complexes on podocyte, so deposits are subepithelial. In type 1, since the antigen is type 4 collagen, which is a component of basement membrane, that's why the deposits are intramembranous or epimembranous. In type 2, again it is subepithelial because it is same as that of PSGN. Type 3, no deposit. MCD, no deposit. In MPGN, the deposits are again subepithelial. The deposits. So you can see the subepithelial deposit in APGN, PSGN and MPGN both. Have you got it? No one will explain you with such a clear concepts. Have you got it? Say yes or no. Have you got it till now? So now I'm drawing two filtration barriers in front of you. I'm drawing the first filtration barrier of PSGN in which the deposits will be subepithelial. And then I will draw the filtration barrier of MPGN. Again, the deposits will be subepithelial, but how to differentiate the two type of deposits then? So here, see the two diagram, you will understand what I mean to say. So this is PSGN I'm drawing or APGN. Whatever you say, post streptococcal glomerulonephritis or acute proliferative glomerulonephritis, the first one. And here I am drawing MPGN, not MPGN, I'm sorry, MGN. Last में भी मैंने शायद MPGN बोला था, it was by mistake. I am teaching you membranous glomerulonephritis, MGN. It is not MPGN, right? Now draw the filtration barrier. So in the center, this is the basement membrane, okay. On one side of the basement membrane, this is the endothelial cell, okay. So these are the endothelial cell. On other side of the basement membrane, these are the visceral podocytes. Can you appreciate the podocytes? Say yes if you can appreciate the podocyte. Please say yes, right? You can appreciate like this, right? Now here, this is bacteria I am drawing. So this is group A beta streptococcus bacteria. I am drawing on the podocyte. That's why this is a planted antigen, right? This is a planted antigen. And here I am drawing GP330. This is the GP330. Here the antigen is GP330. See the location of both of them is same. This one I am drawing is GP330, glycoprotein 330. So this is a fixed antigen. So that is the difference. First you see the difference between them. Everyone give me a thumbs up. So body is forming antibodies against the antigen. So these are the antibodies formed here. So antigen antibody complexes are formed subepithelial, right? And here also the antigen antibody complexes are formed subepithelial, right? So in situ formation of, in both of them, the antigen antibody complexes are formed in situ and the deposition is subepithelial. The deposition is subepithelial here also, here also. So what is the only difference? Here the antigen is planted, which is a bacteria. Here the antigen is fixed, which is the integral component of the podocyte. Till now, if you got it, give me a thumbs up. Sachin, Siddhika, Mushin, I can't see the name of others. Have you got it? If you got it, one more thing. Now, the deposits in both of them is subepithelial. Now, see how to differentiate the deposits on electron microscopy. See, everyone see. Everyone see. Here I am drawing again PSGN or APGN, right? And here I am drawing MGN, membranous glomerulonephritis. So as I have told you, in both of them, this is the basement membrane. In both of them, this is the endothelial cell. And in both of them, why I'm drawing again, there is a reason behind it. And this is the visceral podocyte in both of them, right? You already got the etiopathogenesis. I'm not repeating the etiopathogenesis. I'm directly drawing the deposits now. I will draw the deposits with blue color. Now you yourself appreciate the shape of the deposit. So this is the deposit. It is subepithelial. Okay, let me fill the color also. It is subepithelial in location. These are the deposits I am drawing, the subepithelial only. You know how they are formed. I'm not repeating the etiopathogenesis, how the bacteria is coming and forming it. You already know. So this is the PSGN. Appreciate the shape. The location is subepithelial. I'm not saying, but the shape will be different. So this is the shape of the deposit in PSGN or APGN. Now I'm drawing the same deposit, the subepithelial deposit in Mpgn. See the shape. See the shape. I guess you can appreciate the difference in the shape. Let me fill the color in few of them so that you can appreciate the shape. These are spikes. I'm drawing the spikes. The pointed shape is known as spike. Have you appreciated? No one will tell you with such a beauty, with such a detail. I'm really doing a hard work for you people just to you get the concepts, right? I'm covering medicine also here. The renal pathology will be covered from pathology as well as medicine. So you can see the deposits here are subepithelial. The deposits here also subepithelial, right? Both of them are same, but the shape of the deposit here are lumpy, bumpy, humpy deposits. If you remember the hump of a camel, have you seen a camel? They are looking the hump of a camel, and here the deposits are like the spikes. So these are the small clues that you have to take in the question. Here the bacteria, group A beta streptococcus bacteria, that is the planted antigen, and here the antigen is GP330, which is a fixed antigen. So these are the differences between them. You can see. Everyone give me a thumbs up. Jitne audience utni thumbs up. Have you got it? Shall I proceed ahead? Shall I proceed ahead? So you can see here the deposits will be formed. Here also in both of them, in PSGN and in MGN, in C2 complexes are formed. But it is the fixed antigen on the podocyte. It is membranous glomerulonephritis. It is the planted antigen on the podocyte, that is a bacteria. So it is PSGN. Everyone give me a thumbs up. So both of them in C2 complexes are formed, antigen antibody mediated. Yes or no? Yes or no? That is the thing. Grossly the kidney is enlarged, pale, nothing important. Coming on microscopy, what is the name of the disease? What I am teaching you right now? I am teaching you membranous glomerulonephritis. So as the name indicate, on light microscopy the membrane will be thickened. So there is diffuse thickening of the glomerular basement membrane. See the diagram. Can you see the diagram? In this diagram, can you see this is the glomerulus? Can you appreciate the glomerulus? Yes, you all can appreciate the glomerulus. Inside this glomerulus, I can see multiple capillaries. 1, 2, 3. Multiple capillaries are there. I can see, if I zoom, I can see the on the inner side of the capillary. If you can appreciate some flattened cell. I can zoom the image. You yourself try to zoom it and see. The flattened cells are the endothelium. Very flattened cells are there. And on the outer side, epithelial cells are there. On the outer side, the visceral epithelial podocytes are there. If you can appreciate, zoom the image, can you appreciate the spikes here? If you can appreciate the spike, I have drawn the spikes here. The spikes are the deposit. So because of this deposit, the membrane become thickened. So it is the diffuse thickening of the glomerular basement membrane, the only finding on light microscopy. Rest everything is normal, right? Now the basement membrane is thickened so much that it looks like there are two basement membrane, but actually it is one only. It is known as duplication of the basement membrane. It is not duplicated, it is thickened. लेकिन thick इतना हो गया है कि वो लग रहा है कि double है, but actually it is not double. It is a single membrane only. It is looking that it is duplicated. One more thing that you should notice here cellularity is normal. It is not hypercellular. I cannot find the cells inside that, right? Ikka dukka jo cells hain, wo normal cells hain. I can't find abundant of neutrophils and lymphocytes inside that. I can find only one finding, thickening of the basement membrane. So only one finding is thickening of the basement membrane. That's why it is known as membranous glomerulonephritis. So membranous means thickening of the basement membrane. So thickening of the basement membrane is better seen on a silver stain. So or do a pass stain. Can you see this is a pass stain. In the pass stain, appreciate the thickening of the basement membrane. Thickening. These all are capillary loops. This is the glomerulus. Appreciate the basement membrane is thickened, right? Rest all is normal on light microscopy. Now I am coming on electron microscopy. You already know the location of the deposit. It is subepithelial like PSGN only, but the shape is different. The shape is spiked, not humpy. You can appreciate this is the basement membrane. Everyone appreciate this is the basement membrane. Please appreciate inner is the endothelial. Please appreciate these are podocytes. Can you appreciate? Now see the pink color deposits. Can you see? These are the deposits. So these are subepithelial and they are spike in shape. More or less they are spike in shape, right? Here also you can appreciate the spikes. Here also you can appreciate they are spikes in shape and they are subepithelial. Have you appreciated? On immunofluorescence, the composition is to be said. The composition is again IgG plus C3. Nothing important. It's IgG plus C3 granular deposits are there. That's it. Clinical finding, it is nephrotic syndrome in contrast to PSGN which was nephritic. PSGN में nephritic था, यहाँ पे nephrotic है. Who will help me in filling this table? Anyone among you? Anyone among you? We have completed membranous glomerulonephritis, right? After that, I am teaching you proliferative glomerulonephritis, right? Membranous को fill कराओ. चलो पूरा छोड़ो, सिर्फ membranous को fill कराओ. What is the etiology? Who will tell me the etiology? It is in situ formation of antigen antibody complexes against a fixed antigen. The fixed antigen is GP330. That is present a protein on the podocyte. Grossly, the kidney is large, nothing important, right? Light microscopy, only one finding. Glomerular basement membrane got thickened. The only one finding. Thickening of the basement membrane, it looked so thickened that it looks the duplicated. It looks duplicated. Yes, Sachin, absolutely right. On electron microscopy, the deposits are subepithelial, but the shape is spike. On immunofluorescence, the composition is IgG plus T3, like others. Now, let me complete one more MPGN, then I will make a comparative table between them. Right? MPGN एक और पढ़ लेते हैं. Right? Now, we have studied, just now, we have studied MGN. And now, I am teaching you MPGN. Can you first tell me the full form? Can you? This is membranous glomerulonephritis. This is membranoproliferative glomerulonephritis. So, in membranous glomerulonephritis, only one finding is membrane. That is thickening of the basement membrane. Here GBM get thickened. We have already seen the diagram. Here two findings will be there. One is membranoproliferative में. तो यहाँ पे भी GBM thickening तो होगा. GBM thickening will be there. But proliferation is hypercellularity is also a feature which differentiate MGN from MPGN. We have seen यहाँ पे cellularity was normal in membranous. Have you got it? I'm coming on MPGN, that is membranoproliferative glomerulonephritis, right? It is also known as Misangio capillary glomerulonephritis. यहाँ पे two findings will be there: thickening of the GBM and increased cellularity of the glomerulus and the mesangium, right? Etiopathogenesis, it is again of three types: type 1, type 2, type 3. Don't go in details, it is of three types. Just learn it is of three types: type 1, 2, 3, like RPGN only. Grossly, nothing important. The kidney is pale in appearance, but not important. Light microscopy, this is the diagram. Now you will tell me what you will appreciate in this diagram. You are appreciating two things. Number one, see the glomerulus. सबसे पहले glomerulus देखो. See the glomerulus. Now inside the glomerulus, try to see the two findings. Where are the capillaries? These are the loop of the capillaries. See, on the inner surface there are endothelial cell. No problem in the endothelial cell. No problem in the endothelial cell. See two findings. Number one, the basement membrane got thickened. Basement membrane got thickened. And number two, there is increased cellularity also. You can find most of the cells are lymphocytes and neutrophils. So two findings are there: thickening of the basement membrane and hypercellularity. That's why known as membranoproliferative glomerulonephritis. It is not only membranous. See, the thickening of the basement membrane is best appreciated on silver stain. Now compare the two. Everyone compare the two. No one will give you such a beautiful comparison. See, this is a diagram of MGN. And this is a diagram of MPGN. Now you yourself decide what is the difference between them. In both of them, one thing is common. Thickening of the basement membrane is the common finding here also and here also. Because membrane is a component. Now see, don't only learn. See, the basement membrane is thickened here also in all of them and here also in all of them. The basement membrane is thickened. But one thing which differentiates the two is यहाँ पे cellularity is normal, यहाँ पे cellularity is hypercellular. Compare the cellularity. Can you see the inflammatory cells here? No neutrophils, no lymphocyte. And I can find abundant of neutrophils and lymphocytes here. Everyone give me a thumbs up. Jitne audience utni thumbs up. Everyone give me a thumbs up. Let me see your chat. Give me a minute. So give me a thumbs up. Have you got it? Shall I proceed ahead? So that is the comparison. That is the comparison between membranous and membranoproliferative, the light microscopy. In membranous, as I have told you, the membrane is so thickened that it looks like duplicated. That's why known as duplication of the basement membrane in membranous glomerulonephritis. But in membranoproliferative, also the basement membrane is thickened too much. Just a second. Where is it? I'm going ahead. I'm sorry. Give me a minute. Basement membrane is thickened so much that it is known as double contour basement membrane. It is known as double contour basement membrane or splitting or tram track appearance. You know the meaning of tram track. What is the meaning of the tram track? Tram track means two parallel lines. So the basement membrane is splitted from the between because there are lymphocytes and neutrophils in between. So it is known as tram track appearance. So we are done with these two. Have you got it? Coming on electron microscopy, you have to learn the features. In type 1, it is subendothelial. First time we are saying subendothelial deposit. In type 1, it is subendothelial deposit. In type 2, it is intramembranous. And in type 3, it can be anywhere. There is no fixed location. In type 1, 2, 3, three type of MPGN. In type 1, it is subendothelial. In type 2, it is intramembranous. And in type 3, it is anywhere. Have you got it? And it can present with nephritic as well as nephrotic syndrome. It can be nephritic, it can be nephrotic. So would you like to revise till now? We are done with 5 type of glomerulonephritis till now. Till now, 4 more to go. So I will complete the remaining 4 also. But can you help me in the revision of these 5 till now? Can you help me? So start with Apgn, also known as PSGN. Here in situ deposition of antigen antibody complexes against a planted antigen. The planted antigen is a bacteria, that is gas bacteria. In RPGN, you already know type 1, 2, 3. Type 1, type 2, type 3. Type 1, again it is in situ, but against a fixed antigen. The fixed antigen is the collagen. In type 2, again it is same as that of PSGN. And in type 3, no deposits. Minimal change में no deposits. It is the flattening of the food processes, right? In membranous and membranoproliferative. In membranous, the deposits are subepithelial, right? Like the here the antigen is GP330. Antigen is GP330, which is a fixed antigen of the podocyte. And in membranoproliferative, again, it is of 3 types, but don't go in the details of the pathogenesis of each of them, right? We have seen the important features in the gross also. Only gross of flea bitten kidney is important. Rest of the gross here it is not important. Here gross is normal. That is important in MCD. And here gross are not important. In all of them the kidney is enlarged. That's it. Light microscopy is important for all of them. What is the light microscopy of Apgn? So the glomerulus is enlarged, hypercellular, hyperproliferative. RPGN also enlarged, hypercellular, hyperproliferative, but along with crescents. In MCD, the gross is, the light microscopy is normal. In membranous, only one finding, thickening of GBM. GBM got thickened. In MPGN, 2 findings. Along with thickening of the GBM, you will find hyperproliferation or hypercellularity also. So see the difference. You yourself see the difference between membranous and membranoproliferative. Everyone give me a thumbs up. Everyone. Shall I proceed ahead? Hypercellularity is also a feature of PSGN. But only hypercellularity will be there. GBM thickening is not there in PSGN. Here in MPGN, GBM is also thickened. You got my point? Now in electron microscopy, you tell me the location of the deposits. Here the location of deposits in Apgn, it is subepithelial, but the shape is hump. You know the shape is lumpy, bumpy, humpy, right? Here in RPGN type 1, it is intramembranous. Type 2, it is again subepithelial, humpy, subepithelial because it is PSGN only. In type 3, no deposits. In minimal change, no deposits, but flattening of the food processes there. In membranous, the deposits are again subepithelial like PSGN, but the shape is spike. In MPGN, again type 1, 2, 3. Type 1, type 2, type 3. In type 1, the deposits are subendothelial, the only glomerulonephritis in which subendothelial deposits are there. In type 2, it is intramembranous. And in type 3, it can be anywhere. And composition everywhere is same. It is IgG plus C3. So I'm not discussing separately. सिर्फ इसमें composition अलग जाएगा. IgA nephropathy में IgA आएगा. Apart from it, सब में IgG ही आएगा. Everyone give me a thumbs up. I cannot simplify more than this. These are the heights. Give me a minute. Just a second now. Okay, I cannot open it right now. Okay, anyways, so can I proceed ahead? I cannot see your chat actually. So can I proceed to the next one? Yeah, now I can see. So yeah, so I am proceeding to the next one. Now next two I will take together. The next two I will take together, FSGN and FSGS. It's very easy. Before that, I would like to launch few polls. Are you ready for the polls? I would like to launch few polls now. Right, you have to learn the age, prognosis. Yeah, one more column you have to add here is the clinical features. Kisme nephritic hai, kisme nephrotic. So in APGN, it is nephritic. In RPGN also, it is nephritic. In minimal change, it is nephrotic. Right. Here in membranous, it is also nephrotic. And in MPGN, it can be nephritic, it can be nephrotic. So you have to learn which of them are nephritic, which of them are nephrotic. Everyone give me a thumbs up. This is the most simplified version I can tell you. I cannot simplify more than this. These are the heights. Now I'm coming on the next two. Before that, there are few polls for you. This is the first question. Can you help me in solving it? Which of the following is the characteristic feature? Which of the following is the characteristic feature of MPGN? You tell me characteristic feature of MPGN. Just now I taught you. You tell me the characteristic feature of the MPGN. Can you tell me the characteristic feature of MPGN? Yes? Anyone? Anyone among you? So is it subepithelial deposit? Is it foamy cells? Is it splitting of the glomerular basement membrane? Or is it subendothelial deposit? Right. So you will say MPGN is of three types. Type 1, 2, 3. In type 1, subendothelial deposits are there. In type 2, intramembranous are there. In type 3, anywhere can be there. So subepithelial can be there. Right. So these are not the characteristic feature. The characteristic feature is the C. Right. That is splitting of glomerular basement membrane, which give tram track appearance. I've told you this appearance known as tram track appearance. Give me a thumbs up. So correct answer here is C. The correct answer here is C. Right. Linear deposits along the glomerular basement membrane are seen in. I'm saying along the glomerular basement membrane. I'm asking for intramembranous deposits. So you already know till now we have seen intramembranous deposit at two locations. Intramembranous kahan dekhi hai? Okay. Okay, listen. I taught you RPGN is of three types. Yes or no? RPGN three type. Type 1, 2, 3. 1, 2 and 3. I have taught you MPGN also of three types. Right? Type 1, 2, 3. Right? Yes or no? So who will tell me the location of deposit in each of them? In type 1 RPGN, it is good pasture. So answer is intramembranous. Yes, Siddhika, the answer here is intramembranous. In type 2, it is subepithelial, same as that of PSGN. In type 3, no deposits are there. That was the summary of RPGN. In MPGN type 1, it is subendothelial. And type 2, it is intramembranous. And type 3, it can be anywhere. It can be anywhere. That is the summary of deposits in MPGN. Now see why I have written this. See intramembranous coming where. So can I say type 1 RPGN is intramembranous and type 2 MPGN of intramembranous? Say yes or no. So intramembranous do hi jagah aate hain. Type 1 RPGN or type 2 MPGN. Everyone give me a thumbs up. Everyone. Yes. Here the correct answer is A. Sachin, you are right. Siddhika, you are right. Here the correct answer here is A. Because here again intramembranous deposits are asked. Linear deposits along the glomerular basement membrane. That is intramembranous. So answer is type 1 RPGN and the another name of type 1 RPGN is good pasture. So I will go with it. If the option contains type 2 MPGN also, I will go with that also. So that I want to tell you. Have you got it? The location of the deposit in each of them is very peculiar. You have to learn. You have to learn. Now tell me subepithelial kahan aate hain? Where all subepithelial are present? Is it MPGN? Is it membranous? Is it minimal change or is it diabetic? Diabetic mein to deposits aayenge nahi. I will teach you diabetes later on in secondary glomerulonephritis. In MGN, minimal change disease, MCD, there are no deposits. There is flattening of the food process. There is flattening of the food process, right? But in membranous, yeah, there are subepithelial deposits and the shape of that deposit is spikes. I have told you peculiarly. So go with A or go with answer B. In A, if you say, some students can argue कि ma'am MPGN is of three types. Right, type 1, type 2, type 3. Type 1 is subendothelial. So, of course, type 1 is not the answer. Type 2 is intramembranous. That is also not the answer. But type 3 can be anywhere. As I have told you, it can be anywhere. So, it can be subepithelial also. It can be. So, I agree. Partially, this option is also correct. The type 3 one. MPGN का type 3 can be anywhere. तो subepithelial हो सकता है. लेकिन membranous is always subepithelial ना. So, best is to go with B. अगर B option नहीं होता तो I will go with A. So the best is to go with B. You got my point, Siddhika, Sachin, you got my point. So best is to go with B. Yes, so correct answer here will be B. Right. The next question, you already know the answer. Epimembranous deposits are. So यहाँ पे two answers will be correct. Two answers. What two answers will be correct? Give me two answers which are correct. So one is good pasture, that is type 1 RPGN. Type 1 RPGN, that is intramembranous or epimembranous, or MPGN का type 2. MPGN का type 2. Right? So A and C both are correct. दोनों में intramembranous are correct. Yes, Siddhika, absolutely right. Right? ये answer मैंने गलत लिखा है. It is not epimembranous. Yeah. A and C are the correct answer. You got my point. You got my point. Now you, okay, this is a repeat one. Okay. You tell me subendothelial deposit. Subendothelial सिर्फ एक ही glomerulonephritis में है. Only one glomerulonephritis have subendothelial deposit. Can you tell me, Sachin, Siddhika, the name of that? Can you tell me the name of that? Yes or no? What is the correct answer here? Who will tell me the correct answer? Who will tell me the correct answer? What is the correct answer? Yes. So the correct answer is type 1 RPGN. Type 1 RPGN, it is the subendothelial deposit. So correct answer is C, right? So in this way, based on deposits, many question can come. Many question can come. Till now, we have seen many type of glomerulonephritis. Now I'm coming on the next two. That is, I'm taking next two. Focal, segmental, focal, segmental. One is focal segmental glomerulonephritis. One is focal segmental glomerulosclerosis. What do you mean by that? The two type of focal segmental glomerulonephritis and focal segmental glomerulosclerosis. What is the meaning of the two? What is the meaning of the two? Okay, first one is glomerulonephritis, one is glomerulonephrosis. इसके बाद में आते हैं. पहले understand the meaning of focal and segmental. What do you mean by focal? What do you mean by segmental? For that, I would like to draw a slide. Can you see in the slide? This is a slide of kidney. I'm drawing multiple glomerulus. So imagine this, these all are glomerulus. These all are glomerulus. Now, some of the glomerulus have disease. Just suppose this one is the disease, this one is the diseased, and some of them are healthy. So the disease is known as focal. What do you mean by focal now? You tell me. In focal, out of multiple glomerulus, some are involved, some are not involved. If all of them are involved, the disease is known as diffuse. The disease is known as diffuse. But if some are involved, some are not involved, some are diseased, some are healthy, the disease is known as focal. Have you got the meaning of the focal? Sachin, Siddhika, have you got the meaning of the focal? Now I'm coming on the meaning of segmental. What do you mean by the meaning of segmental here? So let me draw another slide in which I am drawing another multiple glomerulus. Now that all of them are diseased. Imagine all of them are diseased. But in the disease, partially they are diseased and partially healthy. The disease is not involving the complete glomerulus. Have you got it? So this portion is diseased, this is healthy. So this disease is known as segmental. You got my point? What I mean? Now I will draw the two together to explain you the difference between focal and to explain you the meaning between segmental. So draw a slide here, draw a slide here, right? You can see the two slides. You can see multiple glomerulus here and you can see multiple glomerulus here also, right? In the first slide, you can see this one is diseased, and these are healthy, right? In the second slide, you can see half is diseased, half is healthy. Half is diseased, half is healthy. So this condition is known as that focal glomerulonephritis is there. And this condition is known as segmental glomerulonephritis. No one will explain you with such a, कितनी बारीकी से इसमें difference है. Focal का मतलब क्या है? What do you mean by focal? Half of the few glomerulus are involved, few are not involved. Segmental का मतलब क्या है? Segmental का look at one glomerulus. Don't look all. Look at anyone. If in anyone half is diseased and half is healthy, it is segmental. So for commenting on focal, you have to see all the glomerulus. For commenting on segmental, you have to see individual glomerulus. Have you got it? Have you got it? Now I am going to teach you two diseases, right? Focal, segmental, focal. Both of them are focal also, segmental also. But one is glomerulonephritis and one is glomerulosclerosis. You got my point? Now see the two slides. The two slides in front of you. Okay. Let me explain you the two slides first. Let me explain you. Can you see? This is a slide of focal segmental glomerulonephritis. And this is a slide of focal segmental glomerulosclerosis. Now both of them are focal. First we will concentrate on the word focal. Focal का क्या मतलब है? In the first slide, I can see two glomerulus. Glomerulus number 1 and glomerulus number 2. Can you see out of the two glomerulus, I can find this glomerulus is uninvolved. It is absolutely normal. This one, this is healthy. This is healthy, uninvolved. I can see it is a normal glomerulus. But yeah, this glomerulus, I can find a more cellularity here. This area is having increased cellularity. So this one is the diseased, right? So one glomerulus is healthy, one is diseased. So can I say the disease is focal? Right, yes or no? Sachin, right, yes or no? Can I say the disease is focal? Because one of the glomerulus is healthy and one is diseased, right? So disease is focal. Now concentrate on the word segmental. Segmental, see the diseased one. Don't see both glomerulus. See only diseased one. In the diseased one, the disease is only partially involving the glomerulus. Half of it is hypercellular. Half of it is normocellular. So the disease is segmental also. So can I say the disease is focal also, segmental also? One glomerulus, no, intentionally the author, जिसने भी ये book लिखा है, the author have given you two glomerulus in the diagram, without which we cannot explain the meaning of focal and segmental. You got my point? So out of the two glomerulus, one is healthy and one is diseased. We can see this one is healthy, this one is diseased. So disease is focal. And the diseased one may half is healthy and half is showing the disease. So that is known as segmental. You got my point? Coming on the second diagram. In the second diagram also, you can see two glomerulus. Here also glomerulus number 1 glomerulus number 2. Can you see this one? This one is absolutely healthy, normal glomerulus. But see this glomerulus. In this glomerulus, I can find out some abnormal area here in this portion. This area is sclerosed. This area is absolutely sclerosed. So again, the disease is focal. One is involved, one is not involved. So disease is focal, and the involved one may half is involved, half is not involved. So disease is segmental. So actually, both the diseases are focal, both the diseases are segmental, but the disease is different. What is the disease? Now, see the beauty. In the first diagram, the disease is hypercellular. This portion of the glomerulus is hypercellular. That's why known as glomerulonephritis. And this portion of the glomerulus is sclerosed. It is not hypercellular. That's why known as glomerulosclerosis. Everyone give me a thumbs up. No one will explain you with such a beauty. Again, everyone give me a thumbs up. Have you got it? Do you have any doubt in that? Can you see the two diagrams in front of you? Can you see this is focal segmental? This is also focal segmental. So two glomerulus here, two glomerulus here. One is involved, one is uninvolved, one is involved. So that's why the disease is focal. The involved one is half involved, half not involved. So that's why the disease is segmental. But here, the disease is glomerulonephritis because this is the hypercellularity of the glomerulus. That is the disease. Here, glomerulosclerosis is there. That is sclerosis of the glomerulus is the problem. So see the change in the disease. यहाँ पे disease है hypercellularity, hyperproliferation. और यहाँ पे disease है sclerosis. Everyone give me a thumbs up. Have you got it? These are the two next diseases I am going to treat. So first, let's study focal segmental glomerulonephritis, FSGN, also known as mesangial proliferative glomerulonephritis. Right? Here the disease is focal and the disease is segmental. You explain me the meaning. So focal means not all. Some of the glomerulus are involved, some are not involved. And segmental means may involved, a portion is involved, a portion is not involved. Right? So this you can see here, and the disease is only one, hypercellularity, increased proliferation. Can you see increased cells here? What all cells are these? These all are mesangial cells. So hypercellularity of the mesangial cell, that is the disease. Give me a thumbs up. Give me a thumbs up. Here mesangial deposits are there. First time deposits are coming in the mesangium. I taught you 4 locations of the deposit. What are the 4 locations of the deposit? Let me draw a filtration barrier. So this is a basement membrane. On one side, you can notice endothelium. On other side, you can notice visceral podocytes, visceral epithelium. And these are the mesangial cells. Can you notice? These all are mesangial cells. So what is the location of the deposits? The deposits can be intramembranous. So intramembranous deposit till now we have seen at 2 locations. I guess RPGN type 1 and MPGN type 2. Am I right, Siddhika? RPGN 1 और MPGN 2 दो जगह हमने देखा है intramembranous अभी तक. Right? The second type of deposit are subendothelial. Subendothelial तो अभी तक एक ही में देखा है. MPGN type 1. Yes. And subepithelial. Subepithelial we have seen in PSGN, the first one, and MPGN. And we have seen the comparison. One is lumpy and one is spike. Right. Now I'm coming on mesangial deposit. So in FSGN, the deposits are mesangial. In FSGN, the deposits are mesangial. Right. Okay. So Ashish, you want full pharmacology course on Unacademy. Definitely Ashish, I will launch the full pharmacology free course on the Unacademy. But Ashish, are you on Telegram? If you are on Telegram, please tag me a personal message, or on the group, please tag me. I will help you with the links of the last batch. So I will definitely take the live classes, but meanwhile, don't waste your time. If you want the free links of complete pharmacology, I can give you the free links of YouTube and special classes of Unacademy only of the last batch. So meanwhile, watch the recording. Start watching the recordings only. And after some time, few days, I will launch the pharmacology crash course also. Let me first finish pathology. Right, Ashish? So please tag me on the Telegram if you want the free link of the last batch. I can send you all free links of the last batch. The only thing, these are not live lectures. That will be the recordings that you can see. Right? Okay. Anyways, यहाँ पे and the composition is same. Composition is IgG or C3 yoga. I'm done with FSGS, FNGN. Now I am coming on FSGS. I am coming on FSGS. In FSGS, you can see in FSGS, again the disease is focal and segmental. That is, some glomerulus are involved, some are not involved. And the glomerulus which are involved, they are partially involved and partially not involved. Right? Right. And what is the problem? The problem is not hyperproliferation. The problem is solidification or sclerosis. I can see this portion of the glomerulus, this one is solidified or this one is sclerosed. In contrast to FSGN, where this portion of the glomerulus is hypercellular. So this is FSGN, this is FSGS. You can See the disease. You can see the difference between them. Here also in FSGN, two glomerulus are there. This is healthy. This is disease. So one is involved, one is not involved. Here also two glomerulus are there. This is healthy. This is diseased. So one is involved, one is not involved. So both the diseases are focal because some glomerulus are involved, some are not involved. Right? The involved one. See the involved one here. See the involved one here. The involved one is half involved, half not involved. Here also half involved, half not involved. So the disease is segmental in both of them because the involved glomerulus is partially involved, partially not involved. So basically, both the diseases are focal and both the diseases are segmental. But the disease is different. What is the disease? Here the disease is proliferation and here the disease is solidification. Proliferation is glomerulonephritis. Appreciate the hypercellularity and most of the cells are mesangial cells. And appreciate the solidification. Sclerosis is here. So that's why this is known as glomerulonephritis and this is known as glomerulosclerosis. So everyone give me a thumbs up. Ashish, Siddhika, Sachin, others give me a thumbs up. Have you got it? The difference between them? So here electron microscopy pe again diffuse loss of food processes like MCD. That is the feature. Minimal change disease. It is not the immune complexes. Immune complexes will not be there. And composition is same IgG plus CK. So we are done till here. Till here we all are done. So two more are left. Two more are left. Last two are left. IgA nephropathy and chronic. You want me to complete that also and then we will take a comparative analysis of all glomerulonephritis till now. Yes or no? So let me take two more. IgA nephropathy and chronic glomerulonephritis. So first I am taking chronic. Chronic glomerulonephritis. Chronic glomerulonephritis is also known as end-stage kidney disease or chronic kidney disease CKD. So one and the same thing. These are the other names given to that. Right. Now there is no fixed diagram for that. It can result in RPGN. Actually, all till now, how many I have taught you? I have taught you APGN, the first one. I have taught you RPGN, the second one. Then I taught you MCD. Then I taught you MGN and MPGN together. These two together. Then I taught you FSGN and FSGS together. These two together. Abhi tak kitne ho gaye? All of them, listen my point. All of them ultimately result in CKD. Right? So CKD is the end result of all of these. You got my point? So CKD is the end result of all of these. So ye sare ke sare end mein CKD mein hi convert honge if not treated. If treated, they will stop. But if not treated, the end result of all of them is CKD. So most rapidly among all of them will convert. Lekin the speed of conversion is different. Most rapidly conversion occurs in RPGN. That's why the name is RPGN. Rapidly progressive glomerulonephritis. Within few weeks, it will convert into CKD. That's why prognosis is very poor and you have to treat very abruptly. You got my point? Others also convert into CKD but gradually and slowly. You got my point? So RPGN in 90% of the cases convert into CKD. Membranous also convert in 50% cases. Membranous proliferative also convert in 50% cases. FSGS also convert. IgA nephropathy, APGN. APGN only 1% chance of converting into CKD. So APGN have best prognosis. Everyone give me a thumbs up if you got it. So ultimately all of them are converting into CKD. In CKD is the only glomerulonephritis in which kidney becomes small grossly. Kidney contracted, rest all kidney expand. In all of them, I taught you kidneys enlarged, kidneys enlarged, kidneys enlarged. But in CKD, it is the end kidney. Kidney is as small as 50 gram. As small as a very small kidney. Right? 50 gram. And the surface of the kidney is granular. Can you appreciate the granularity? The granularity. Granular surface is very important grossly. And the cortex is narrow, atrophic. Cortex is narrow, atrophic. And you can see the cortex is narrow and atrophic. That's it. Coming on the light microscopy, this is the diagram. Can you see where are the glomerulus? It's very easy diagram, funny diagram. Can you see this is a glomerulus, this is a glomerulus, this is a, I can see 3 or 4 glomerulus here, I guess, right? Inside the glomerulus, I cannot see anything. The glomerulus is completely converted into acellular mass. Acellular hyalinized glomerulus. The glomerulus is completely converted into acellular mass, that is hyalinized tuft. The glomerulus converted into hyalinized tuft. I can't see capillary, I can't see endothelium on one side, epithelium on other side. No, complete glomerulus are gone. They converted into acellular eosinophilic hyalinized mass. Everyone give me a thumbs up. That's all about the glomerulus, right? Glomerulus count. The glomerulus reduce in number. पूरे disappear हो जाएंगे और जितने बचे हैं, they will convert into hyalinized mass. That is about the glomerulus. See the tubules also. Tubules के अंदर you will find atrophy and hyaline droplets. Where are the tubules? Let me show you the tubules. These all are PCT, loop of Hanley, DCT, collecting duct. These all are tubules. So tubules are atrophied. You can see small tubules. So we have seen the glomerulus, we have seen the tubules. See the blood vessels. One of the blood vessels is shown here. So can you see this is one of the blood vessel. The blood vessel is showing, what does it showing? The blood vessel is thickened because it is showing arteriosclerosis. There is atherosclerosis in the blood vessel, arteriosclerosis. And the last one, see the background. Interstitium, the background. The background, can you see in the background these cells? What are these cells? This cluster of cell, this cluster. The cells present in the background are lymphocyte, no neutrophil. Mind, there is no neutrophil. So chronic inflammatory infiltrate. So comment on the four things. Comment on four things in this diagram. Comment on glomerulus, comment on blood vessel, comment on tubules, and comment on interstitium. Who will comment on the four things one by one? Glomerulus may write down one thing, they converted into acellular masses. Can you see this one, they are hyalinized, right? Blood vessel may show, they show arteriosclerosis, arteriosclerosis, the wall is thickened. Tubules may, they are atrophied. You can see small tubules. And interstitium may, background may chronic inflammation, not acute. That is only lymphocyte, not neutrophil. Everyone give me a thumbs up. So that is the summary of chronic glomerulonephritis. The chronic glomerulonephritis is done. I'm coming on the last one, IgA nephropathy. Everyone give me a thumbs up. The last one, the ninth one is IgA nephropathy. The last one. Then I will do a comparative analysis of all 9. The last one is the IgA nephropathy. IgA nephropathy, also known as Berger's disease, also known as IgA nephropathy. It is the most common type of glomerulonephritis throughout the world. So out of the 9 type of glomerulonephritis, this was first time described by a physician known as Berger. The name is Berger. So that's why it is known as Berger's disease. And it is the most common glomerulonephritis. It always occurs after tonsillitis. After either tonsillitis, that is upper respiratory tract infection, tonsillitis pharyngitis, or after gastrointestinal infection. Now compare the first one, PSGN or APGN, the first one and the last one. The last one I am teaching you is IgA nephropathy. The first and the last. Compare. Both of them are after infection. The PSGN or APGN is after respiratory or skin infection. I told you the person is either having tonsillitis or the skin infection. This one is after respiratory or GIT infection. So see the difference. So this also occurs, this also occurs. This occurs 7 to 10 days after infection, and this occurs 4 to 5 days after infection. So see the incubation period is different. Here exact mechanism is not known why it is happening. Exact mechanism is not known. Some people say it is due to antigen antibody complexes formation. So what is the problem? Why it is known as IgA nephropathy? Why it is known as, see, I have not put the pathogenesis here. I will draw it for you. I forgot to put the slide. What is IgA nephropathy? What is happening here? Here, the B lymphocytes become abnormal. These are B lymphocytes. These are B lymphocytes. They become mutated. They become abnormal, right? They become abnormal. So the plasma cells formed out of it. B cell convert into plasma cell. So plasma cell will become abnormal, right? So plasma cell will form antibody. The antibody is IgA antibody. This one antibody, there are 5 type of antibodies now. Gamma, IgG, IgA. So this one is IgA. In contrast to all others, यहाँ पे IgG था composition, right? This antibody is IgA. Listen. This is abnormal IgA, not normal IgA. This IgA is abnormal. Listen. So it is acting as the foreign material for the blood. You got my point? This is antibody, but this is abnormal antibody. That's why it is acting as an antigen. So body is forming antibody against antibody. You got my point? So body will form antibody against this IgA antibody. So antigen antibody complexes will be formed. In the antigen antibody complexes, who is the antigen? Who is the antibody? Who will tell me? The antigen is IgA antibody. And the antibody against antibody, this antibody can be IgG, can be IgA. This can be anything. But it is formed against IgA antibody, which is abnormal due to the abnormal B cells and abnormal plasma cells. Have you got my point? So antigen antibody complexes are formed, and these complexes get deposited exclusively in mesangium. Mesangia. They will deposit only in mesangium, not intramembranous, not subepithelial, not subendothelial, in the mesangium. That's why this is mesangial disease. IgA nephropathy, because IgA is abnormal. That is the antigen here. Give me a thumbs up if you got it. Everyone give me a thumbs up. This is the pathogenesis. Shall I repeat again, or have you got it? So here IgA become abnormal. Body will form antibodies against the IgA, right? So IgA antigen antibody complexes will be formed, and that will be deposited in the mesangium. So draw a flowchart like that, right? In the light microscopy, there is no fixed pattern. There is no diagram. It can look like FSGN, FSGS, membranous, membrano, rarely RPGN. There is no fixed pattern, so don't learn the diagram. Electron microscopy deposits only at one place, mesangium. Can you see these mesangial deposits? Deposits will be in the mesangium. In the mesangium. You got it? Immunofluorescence is important. Here the composition is IgA, with or without IgG. क्योंकि antibody against antibody can be IgG, but main antibody जो antigen का काम कर रही है वो IgA है. So that is the hallmark of this disease, immunofluorescence. Give me a thumbs up. Give me a thumbs up. It can be nephritic, it can be nephrotic. Right. So see the differences between post-streptococcal glomerulonephritis, the first one, and IgA nephropathy, the last one. Post-streptococcal occurs after 7 to 21 days after the infection. This one is occurring after 1 to 4 days after the infection. Here recurrences are very common. वहाँ पे recurrences were rare. Right. So these are the differences between them. I'm not launching the polls right now. I am done with the 9 type of glomerulonephritis. Are you people with me? Are you people with me? We are done with the 9 type of glomerulonephritis now. Now I want to make a comparative analysis between the 9 type of glomerulonephritis. You want to revise with me? Do you want to revise with me? So just a second. Let me see the table. If you want to revise with me, I will help you with the revision. Okay. Here is the table. You can see this table. So in this table, you can see the 9 names given here. 9 type of glomerulonephritis. I have covered all. The most important feature you have to learn here is the 3 type of microscopy, right? So you have to tell me the deposits, the location of deposit, composition. Okay. Let me start with the 3 type of microscopy. Okay. Let me start with immunofluorescence, the easiest one. So only thing I would like to say, in IgA nephropathy, immunofluorescence contain IgA. Apart from it, everyone else contain IgG plus C3. Only IgA have IgA with or without IgG. So that is the summary of immunofluorescence. Are you agree with this summary? Immunofluorescence is done. Immunofluorescence किसी का भी पूछ लें, answer is same, IgG plus C3. But IgA nephropathy का अलग है. It contains IgA along with or without IgG. I have told you, yes, IgG plus C3, Siddhika, absolutely right. Right. So that is the first thing you must learn in all of them. Right. The second thing which I would like to tell you is the electron microscopy of all of them. We are done with immunofluorescence. Right. Now I am teaching you the electron microscopy of all of them. Please tell me the location in each of them. Siddhika, would you tell me? Others, would you tell me? Sachin, would you tell me APGN में क्या location था? The location was subepithelial and the shape is hump. जहाँ पे shape पता है, shape भी बताओ. Location and shape, you tell me. RPGN में there are 3. So तीनों का बताओ. Type 1, Type 2, Type 3. तीनों का बताओ. Who will tell me? Type 1 का क्या है? Type 2 का क्या है? Type 3 का क्या है? In Type 1, it is intramembranous. In Type 2, again it is subepithelial. In Type 3, no deposits. No deposits. Right? Coming on minimal change. The third one, minimal change. Who will tell me the minimal change ka summary? Minimum change, minimal change. There are no deposits, but there is fusion. Fusion, or there is a fusion of the podocytes or flattening of the podocyte. Fusion or flattening of the podocyte. Absolutely right, Siddhika. Yes, right. Coming on the membranous and membranoproliferative. First, let's talk about the membranous. Membranous में भी subepithelial. तो subepithelial यहाँ भी थे, यहाँ भी हैं, लेकिन यहाँ पे the shape is spike. The shape is spike. मैंने specific बताया है, shape is spike. Yes, Siddhika, absolutely right. Coming on Apgn. Can you tell me Apgn, Siddhika, the 3 type of Apgn. Apgn is also of 3 type like RPGN. Type 1, Type 2, Type 3. The 3 types of Apgn. You can see the 3 type of Apgn. So Type 1, it is subendothelial. Subendothelial एक ही जगह आएगा और कहीं नहीं आएगा. Please learn it. Type 2 is intramembranous. And Type 3 can be anywhere. It can be anywhere. Right? FSGN or FSGS में you can skip this portion because there are no deposits. Right? IgA nephropathy में deposits are typically in mesangium. And chronic again deposits are not important. So see the summary of the deposits. Now split them. Which of them are intramembranous? Which of them are subepithelial, subendothelial, and mesangial? So please split them into 4 components. Everyone give me a thumbs up. So I am done with the summary of immunofluorescence. I am done with the summary of electron microscopy. Light microscopy, I will show you 9 images one by one, and you will tell me the summary of each of them. वो end में लेते हैं. उससे पहले gross बताओ मुझे. Tell me the gross. So APGN का gross is important. It is flea-bitten kidney. It is flea-bitten kidney. Rest all gross, the kidney is enlarged. यहाँ पे kidney is normal. In minimal change, the kidney is normal. Otherwise, kidney is enlarged. Only in chronic, the kidney is small, contracted with granular surface. So that is the important point about the gross. I would like to comment. So question या तो flea-bitten पे आएगा, या MCD पे आएगा, या chronic पे आएगा. From gross. Otherwise, gross is not important of others. Everyone give me a thumbs up. Everyone give me a thumbs up. So till now, what we have completed? We have completed immunofluorescence summary. We have completed electron microscopy summary. We have completed gross summary. Etiopathogenesis you already know. In which of them, what is the etiopathogenesis? I have discussed the flowcharts of all of them. Right. Now let me discuss the light microscopy, the 9 diagrams. The first diagram I am showing right now is Apgn. So what is the summary of Apgn? So Apgn, this is the diagram. Apgn also known as PSGN. It is post-streptococcal glomerulonephritis or acute proliferative glomerulonephritis. You can see this is the diagram. In this diagram, this is the glomerulus. I can find 3 findings. The glomerulus is enlarged in size. The glomerulus is increased in cellularity, hypercellularity, and increase in proliferation, hyperproliferation. The cells are both acute and chronic. So inside this diagram, I can find out neutrophils also, and I can find out lymphocytes also. If you zoom, you can see multilobated as well as single nucleus cell. Right. So cellularity is acute and chronic both. So that is the summary of Apgn. Would you be able to draw? Shall I proceed ahead? And this is the light microscopy. Electron microscopy, you already know the subepithelial deposits, and immunofluorescence you already know, right? RPGN is of 3 types. So light microscopy ek hi hai. This is the summary of light microscopy of RPGN. Coming on the second type of glomerulonephritis, RPGN. In RPGN, you can find out there is a glomerulus. Can you see this is the glomerulus? Inside this glomerulus, appreciate the crescent. Can you appreciate this crescent? This crescent I am talking about. This is the crescent, right? This crescent is compressing the remaining glomerulus. The remaining glomerulus is increased in size, increase in cellularity, and increase in proliferation, exactly same as that of PSGN. You can see the cells are both again. They are neutrophils also and they are lymphocytes also. The only feature which differentiate RPGN from PSGN is the crescent formation, and crescent is the hallmark here. In RPGN, it is the pathognomatic feature, and the number of crescents is important for the prognosis. So that is RPGN, right? So we are done with the light of RPGN also, the light microscopy. Coming on the third glomerulonephritis, MCD. Can you tell me the diagram of MCD? Minimal change disease. Light microscopy is normal. There is no problem, and so absolutely normal glomerulus. Absolutely, there is no problem in the glomerulus. It's absolutely normal. ये normal होना ही इसकी abnormality है. That you miss the disease on light microscopy. So on light microscopy, you cannot pick the disease. Give me a thumbs up. On electron microscopy, you will find flattening of the podocytes. The flattening of the podocytes is seen on electron microscopy, not on light microscopy. Coming on the next two, membranous glomerulonephritis and membranoproliferative glomerulonephritis. ये दोनों हम next लेंगे. So what is the difference between them? What's the difference between them? In membranous, you will find only one thing, GBM thickening. GBM thickening यहाँ पे भी है, GBM thickening, right? But here it is the only feature. Here proliferation also there. So GBM के साथ hypercellularity is also there. Here cellularity is normal. Have you got it? GBM is thickened in both of them, so different appearance is there. Here thickening of the GBM is known as duplication of GBM. It looks like it is doubled, but actually it is not doubled. Here thickening of the GBM is known as tram-track appearance. Tram-track appearance. So now the appearances are different. Give me a thumbs up. No one will give you such a crystal clear view of the glomerulonephritis. This is the diagram of membranous. Can you appreciate the glomerulus? Inside the glomerulus, only one finding. All the GBM, you can appreciate. There is spike-shaped subepithelial deposits, and they are thickened. They are thickened, they are looking duplicated. That's the only finding, but there are no cells inside. There are no cells, that's why cellularity is normal. See this diagram, MPGN. You can see again a glomerulus, inside which two findings are there. If the glomerulus membranes are thickened, that is the first finding, and you can appreciate the cells, neutrophils, lymphocyte both. So two findings are there, hypercellularity and thickening of the GBM, which is known as tram-track or splitting. Give me a thumbs up. Give me a thumbs up. Coming on the next two, FSG and FSGS. Focal segmental glomerulonephritis, focal segmental glomerulosclerosis. You already know the two diagrams. Just now I have explained you the two diagrams. In both the diagrams, in both of them, this is a diagram of FSGN. This is a diagram of FSGS. Focal segmental, the disease is focal, the disease is segmental. Here two glomerulus are there. Here also two glomerulus are there. What do you mean by focal? One glomerulus is healthy, one is diseased. Here also one is healthy, one is diseased. So can I say the disease is focal? Few glomerulus are involved, few are not involved in both of them. So that's why the disease is focal. Coming on the meaning of the segmental, the involved glomerulus. So this one is diseased now. So half is diseased, half is normal. Here also this one is diseased now. So half is diseased, half is normal. So the disease is segmental in both of them. So the disease glomerulus, a part of it is involved, a part of it is not involved. So the disease is focal, the disease is segmental, but the disease is different. Here problem is hypercellularity, that is glomerulonephritis, that is proliferation, and most of the cells are mesangial cells which are getting hyperproliferated. And here the problem is sclerosis. Half of the glomerulus gets solidified. It is hyalinized and sclerosed. So the problem is glomerulosclerosis. So that's why it is glomerulonephritis, it is glomerulosclerosis. You're not giving the thumbs up. Are you getting all these points? Yes or no? Or it is going bouncer for you. Are you getting it? The next one, eighth one is chronic. Chronic. This is the diagram of chronic. Can you see? You have to comment on 4 things here. What 4 things? Comment on glomerulus, comment on tubules, comment on blood vessel, and comment on interstitium. Can you see? These are the glomerulus. Glomerulus 1, glomerulus 2, glomerulus 3, glomerulus 4. All of them, inside them, they convert into acellular mass. That is, they are hyalinized. So all the glomerulus are hyalinized. See the tubules. Can you see the tubules? These are the tubules. All the tubules are small. They are atrophied. So all the tubules are atrophied. Right? See the blood vessel. I can see one blood vessel. So the blood vessel is showing thickening of the wall. That is, it is showing arteriosclerosis. Right? And see the interstitium. Can you see the background? The interstitium. In the interstitium, see the collection of cells. Now, please see, Siddhika, all these cells are only chronic. That is, they are lymphocyte, they are not neutrophil. So, chronic inflammation. So, that is the summary of chronic glomerulonephritis. The last one is IgA nephropathy. There is no diagram of it. Any of the diagram can work. There is no fixed diagram. Only one finding, the deposits will be mesangial. The deposits will be mesangial. Exclusive deposit will be mesangial here. All the deposits will be mesangial. That is the primary glomerulonephritis. I am done with all primary glomerulonephritis, the 9 type of primary glomerulonephritis. Everyone give me a thumbs up first. Do you have any doubt in that till now? Till now, do you have any doubt in that? We have covered the 9 type of primary glomerulonephritis in a beautiful comparative manner. So from today morning, this is my 5th hour. I guess I am taking the lecture. Yes or no? So those who are attending my lecture from the morning, so they all know that I have covered all 9 in a comparative manner. Those who have missed my past, the last lectures, episode 1 and 2, I request them, they are available on the YouTube. Please go and see the recording. Please everyone see the recording, have a look on the recording. You yourself will realize how important topic it is. And we have covered the 9 type in a comparative manner. Now, any question either from pathology or any question from medicine, the glomerulonephritis question, you can crack it. The question can be one-liner, the question can be image-based, the question can be big clinical question. If you have knowledge of all the glomerulonephritis, especially their pathogenesis and the 3 type of microscopy, you are able to solve all the questions based on glomerulonephritis. That is my challenge to you. Still, you try it out. You figure it out. Still, if you find any difficulty that, ma'am, this question doesn't fit from your notes, I have watched your lecture, still I cannot find this question, I cannot answer this question, kindly get back to me. I will help you in solving that. So I can challenge any question based on primary glomerulonephritis. You can technically solve it now if you have watched my lectures attentively. Yes or no? So now it's time to start the secondary glomerulonephritis. So let me start the secondary glomerulonephritis now. Shall I start the secondary one? We are done with the 9 primary one. The 9 primary one are over. Now I am coming on the secondary glomerulonephritis. In secondary glomerulonephritis, what is the problem? There is some other systemic disease. There is some other secondary disease, not the primary. So glomerulus is involved secondarily. So here, most important, I am going to teach you diabetes. Here, after that, we will start hereditary also. In secondary glomerulonephritis, I am teaching you diabetic nephropathy. The name indicates the main disease here is the diabetes. Diabetes is very common, especially in developing countries like India. So there are 2 types of diabetes, type 1, type 2. We all know that. I'm not teaching you diabetes here. I want to teach you the effect of diabetes on the kidney. That is diabetic nephropathy. So how diabetes results in damage of the glomerulus. So that is diabetic nephropathy or diabetic glomerulopathy, I must say. So that is a type of secondary glomerulonephritis. Here, main disease is not involving the kidney. Main disease is something else, that is diabetes. And hyperglycemia and the diabetes results in nephropathy, that is glomerulonephritis. That's why it is secondary. It is more common in type 1 diabetes as compared to type 2 diabetes. So we can understand that, right? So, okay. I will tell you 3 things here. What 3 things? First, I will tell you the effect on the glomerulus. Then I will tell you the effect on the blood vessel. Then the effect on the tubules. Effect on tubules, effect on blood vessel, effect on glomerulus. Let's first talk about glomerulus. So glomerulosclerosis is there. Again, glomerulonephritis is not there. In diabetes, glomerulosclerosis is there. I will tell you the reason, right? And glomerulonephrosis is of two types, diffuse and nodular. Now listen, diffuse and nodular. I will show you the diagram. This is the diagram of diffuse. This is the diagram of diabetic glomerulosclerosis is of two types. What I am teaching you? I am teaching you diabetic nephropathy. Here, involvement of glomerulus occur. Let me talk about glomerulus, glomerulonephritis. So ये glomerulonephritis नहीं होता है, glomerulosclerosis होता है. पहली बात, the first thing, and it is of two types. The first one is the diffuse and second one is the nodular. उसके नाम में ही उसका मतलब छुपा है. The name itself indicates its meaning, right? Let me first explain you the diffuse. Diffuse, right? This is the diagram of the diffuse. In this diagram of the diffuse, can you see this is the glomerulus? Appreciate only glomerulus. Don't see tubules, blood vessel and interstitium. See only glomerulus. Inside this glomerulus, hyaline. What is hyaline? Hyaline is pink color, eosinophilic, acellular, structureless mass. Pink color, that is eosinophilic. Structureless, acellular, homogeneous mass. The hyaline get deposited at 4 places. That's why it is known as diffuse. So let me show you the 4 location hyaline kahan pe hai. Number 1, can you see the pink color mass at the center? This is mesangium. So hyaline is deposited in the mesangium, mesangial matrix. Number 1. Have you appreciated? Yes, you all can see the mesangial deposits. Number 2, can you see the multiple blood capillaries here? These all are blood capillaries inside the glomerulus, right? Appreciate the blood capillaries. See the lining of the blood capillaries, that is basement membrane. So the hyaline is deposited in the basement membrane also. So basement membrane got thickened, right? So hyaline is deposited in the basement membrane, thickened basement membrane. Number 2, in the basement membrane of the capillaries, right? Number 3, hyaline is deposited in the form of the cap of the capillary. ऐसा लग रहा है कैपिलरी ने टोपी लगाया है. It is known as the cap of the capillary. Let me show you. Can you see this portion? It is like the cap of a capillary. See this portion, cap of a capillary. See this portion, cap of a capillary. So it is deposited in the form of the cap of the capillary. Number 3. And last, it is deposited in the Bowman's capsule. Can you see here in parietal layer of the Bowman's capsule, right? This is known as capsular drop. So at 4 places this hyaline is deposited. And that's why the disease is known as diffuse. Everyone give me a thumbs up. Everyone. What are the 4 places? So diffuse one is more common. First, let me teach you diffuse. Diffuse mein hyaline is deposited at 4 places. 1, 2, 3, 4. So what are the 4 places? Hyaline is deposited at 4 places. It is deposited in mesangium. It is deposited in glomerular basement membrane. It is deposited in capillary wall, the cap of a capillary, and it is deposited in Bowman's capsule. That is capsular drop. First, everyone give me a thumbs up. So can you appreciate? Yes. It is the more common as compared to nodular. Here, hyaline is deposited in all the parts. Basically, 4 parts यानी all parts में ही हो गया वो. Right? That's why known as diffuse. So what are the 4 parts? सबसे पहले basement membrane, उसके बाद mesangial matrix, उसके बाद Bowman's capsule और उसके बाद cap of the capillary. So the most common and earliest in the basement membrane. Appreciate at the 4 parts I have shown you. So this is diffuse one. The second one is the nodular one. Here also hyaline will be deposited, but not everywhere. Not everywhere. See the diagram first. Where is the hyaline? Where is the glomerulus? This is the glomerulus. In this diagram, hyaline is not deposited everywhere. It is deposited in the form of the circles, in the form of the nodule. So hyaline is basically forming small nodule. It is not deposited in the Bowman's capsule, the capillary, the basement membrane. No, it is forming small nodules. That's why known as nodular. Give me a thumbs up. So it is not diffuse. This one is nodular. That is the only difference between them. दोनों में हो एक ही बात रही है, दोनों में हाइलाइन डिपोजिशन है, लेकिन डिफ्यूज में हाइलाइन डिपोजिशन 4 जगह पे है, नोडुलर में एक ही जगह पे है इन द फॉर्म ऑफ मल्टीपल नोड्यूल्स. गिव मी अ थम्स अप. व्हिच इज मोर कॉमन? डिफ्यूज वन. बट व्हिच इज मोर स्पेसिफिक? नोडुलर वन. नोडुलर वन का दूसरा नाम है, देयर इज वन मोर नेम गिवन टू नोडुलर ग्लोमेरुलोस्क्लेरोसिस ऑफ द डायबिटीज. इट इज नोन एज केडब्ल्यू किडनी. इस पे बहुत एमसीक्यू आता है, रिपीटेड मेनी टाइम्स इन योर एग्जाम्स. It is known as Kimmelston-Wilson kidney. What does it known as? It is known as Kimmelston. It is known as Kimmelston-Wilson kidney, KW kidney, and it is the most specific or pathognetic feature. So compare the two. Have I done the comparison? Yes. Compare the two. Can you compare the two types of glomerulonephrosis, glomerulosclerosis in the diabetes? Please do the comparison. Everyone here, everyone. So can you see a glomerulus here? Yes, you can see. And can you see a glomerulus here? Yes, you can see. In both of them, the hyaline. What is hyaline? First say what is hyaline. It is pink, eosinophilic, structureless, homogeneous mass. So that is deposited in both of them. Here in diffuse, it is deposited at 4 places. Let me show you. Number 1, mesangium. Number 2, basement membrane, glomerular basement membrane. Number 3, capillary cap, the wall of the capillary cap. And number 4, Bowman's capsule. So that's why it is known as diffuse. In number 2, in nodular one, hyaline is deposited in the form of the nodules, not at multiple places. So it is deposited in the form of circular oval nodule. Circular oval nodule. So you can see the difference. Everyone give me a thumbs up. Now, if the question comes, which is more common, answer is this. Question comes, which is more specific, answer is this. Nodular wala, another name is given, Kimmelston-Wilson kidney. It is known as KW kidney based on the scientist who has discovered it. Give me a thumbs up. Everyone give me a thumbs up. That is about the glomerular changes. Now coming on the blood vessel. Now see the blood vessel in both of them. In both of them, one blood vessel is shown. Can you see this is a blood vessel here? The wall is thickened showing hyaline deposition. Can you see a blood vessel here? The wall is thickened showing hyaline deposition. So hyaline thickening of the arteriole is a common feature in both. That is not different. Glomerulus दोनों का अलग है, लेकिन blood vessel दोनों का same है. Blood vessel में change is same. So in the blood vessel, the same change is there. Hyaline arteriosclerosis. Hyaline arteriosclerosis. The last is the tubules. Tubules भी दोनों में same है. Please notice the tubules here and here. Here I can see these are the tubules. These are the tubules. And here I can see these are the tubules. See the cells of the tubules. Can you see the cells of the tubules? Inside the cells of the tubules, you can see vacuoles. You can see the vacuoles. Can you appreciate? I cannot zoom it. Inside the cells of the tubules, please appreciate the vacuoles are there. This is known as Armani-Ipston lesion. The name of the scientist only. Armani-Ipston lesion. Armani-Ipston lesion is also common in both of them. Have you got it? So I am done with diabetes. Diabetic glomerulosclerosis. There it is of two types, diffuse and nodular. In both of them, only glomerulus is different, right? Glomerular findings are different, right? Glomerular finding is different in both of them. But blood vessel and tubular finding is same in both of them. Have you got it? So can you tell me the summary? What is the glomerular finding? Here also hyaline deposited, here also hyaline deposited. But here 4 places, that's why diffuse. Here only nodules, that's why nodular. Give me a thumbs up. Here 4 places is basement membrane, glomerular basement membrane, mesangium, capillary cap, and Bowman's capsule, that is capsular drop. Right? So that's why. If you ask me which is more common, this is more common. If you ask me which is more specific, this is more specific. It is also known as KW kidney. Coming on blood vessel. Blood vessel of both of them show hyaline arteriosclerosis, hyaline arteriosclerosis. Tubules of both of them show vacuoles, that is known as Armani-Ipston lesion, Armani-Ipston lesion. That is the summary of diabetes. I am done with diabetes. I am done with secondary glomerulonephritis, and that is diabetes. Everyone give me a thumb. Everyone. Here I would like to stop now, right? I would like to stop now. Let me declare my next lectures, tomorrow's lecture, then you people can go, right? So tomorrow morning, I will again start, I guess at 7 o'clock. I will start morning 7 o'clock and continuously I will take 6-hour lecture, right? The free lectures on the YouTube only. So 7 to 9 will be the first, 9 to 11 will be the second, and 11 to 1 will be the third. So 2 hour, total 6-hour lectures will be there on the renal system only, right? So in the first lecture, I will continue with secondary glomerulonephritis and hereditary glomerulonephritis first, right? So I will teach you diabetes. We will revise once again. We will start with diabetes, revise diabetes, the secondary one जो अभी किया, उसमें कुछ polls करेंगे. Then we will do SLE, we will do HS purpura, we will do other. Then we will do the 4 type of hereditary glomerulonephritis. So glomerulonephritis will be over, right? After that, we will do pyelonephritis. We will do tubulointerstitial diseases, that is ATN, acute tubular necrosis. We will do obstructive uropathy, that is calculus, right? That is in the second lecture. In the third lecture, exclusively, I will teach you renal tumors, the malignancies of the kidney, the renal tumors. In adults also, in children also. In children, I will continue with the Wilms tumor. And we will do some image-based and clinical question practice in the end. So tomorrow, again, 3 lectures, renal pathology will be packed. So today 3 and tomorrow 3, total 6 lectures, complete renal pathology. Any question, any question from any exam, whatever is the exam, whether it is clinical, non-clinical, whatever question, you can be able to solve that question after attending my 6 lectures of pathology, renal pathology, right? So don't forget to continue on YouTube, the same YouTube channel of Unacademy Live, where you are attending right now, tomorrow morning, right? There are few announcements for you. On the Unacademy, new batch is launched for the 2023 NEET PG. That is for freshers also, for repeaters also. So if you are having that, I mean, if you want to attend these batches, you can take the subscription. Today at 7 in the evening, Siddhika, in the evening, I'm talking about morning. Tomorrow morning at 7 a.m. in the morning, I will start. Kal morning, 7 se 1 baje tak. We are having 6-hour class. Not today, right? And these are the various plans available. The Plus, the Iconic, the Light, the MBBS Prof 1 and UPSC CMS. So in the Plus, you will get only Unacademy. In Iconic, along with Unacademy, you will get Preparative also. In Light, you will get only test series. In Prof 1, Anatomy, Biochemistry, Physiology classes will be there. And here UPSC classes will be there, UPSC CMS classes. So whatever you are planning according to your target, you can take that of subscription, that duration subscription according to your wish or need. Longer the duration, cheaper it is. So go with a longer subscription. Whatever subscription you are planning to take before payment, please apply my code Sachdev and help me in distributing this code to your all friends, colleagues, batchmates, seniors, juniors, interns, any medico throughout the globe. Please help me in distributing the code so everyone can get the discount, right? So the code is my surname Sachdev, Sachdev, Sachdev without space stamp. I am Dr. Priyanka Sachdev. So this is Sachdev, right? So thank you very much for being with me. Siddhika, I can send you the notes on the Telegram, ask on the Telegram, right? So thank you for being with me. Thank you for giving your precious time to me. And I request you to come again tomorrow morning and we will continue with renal pathology, finish renal pathology. After renal pathology, we will move to other systemic pathologies, CVS, CNS, Respi, GIT, hepatobiliary, bone soft tissue, male genital, female genital, breast. We will continue all chapters of systemic pathology one by one. Right. Bye-bye. See you. Study hard. All the best.